It's time for the 3-question warm-up for Neurology 7. Let's get going. First question here, what are the 4 most common sequelae of meningitis in children? First one is hearing loss. After that, it's going to be intellectual disability, then seizure disorder, and then spastic paralysis. Next question, a ring-enhancing brain lesion on CT in a patient with seizures suggests what? Well, I want you to think of a brain abscess. Now, sometimes you'll also see neurocysticercosis or toxoplasma causing ring-enhancing lesions, but think about some kind of brain abscess. And then the last one here, a 30-year-old woman patient is in the office with a complaint of facial pain. She describes that whenever her face is lightly touched, that she experiences incredible electrical light pain. What is the first-line treatment for this condition? So this sounds like trigeminal neuralgia, right? So we said that the first-line treatment for trigeminal neuralgia is carbamazepine. All right, that's it for the 3-question warm-up. Now let's get on to the lecture.
So, I hear one of the other lecturers has been making some very unprofessional remarks about me. What's his name? Dr. Doofus? Dr. Goofus?
Dr. Lewis.
No, what's his last name?
Lewis.
Wait, what? His name's Lewis? Lewis? Wow. I bet he got beat up every single day in junior high. No wonder he's so socially awkward. In this video, we're going to be talking about various types of intracranial hemorrhages. Now, these are definitely high yield. You need to be able to recognize and diagnose these hemorrhages based either on the classic history or by looking at a CT or MRI. So we're going to start with the most superficial bleeds and then progress to the deeper bleeds. The most superficial type of intracranial hemorrhage is an epidural hematoma, where you have bleeding between the skull and the dura. Now, epidural hematomas and subdural hematomas are at least a 4-star topic for Step 2. You're going to have at least one question asking you to identify one of these. Now, an epidural hematoma is generally caused by an arterial bleed. The most common cause is head trauma that lacerates the middle meningeal artery. Now, clinically, this classically causes something called a lucid interval, where the patient gets whacked in the head and they might lose consciousness for a few minutes. Then they wake up and they appear to be normal or lucid for a few hours. And then they start to get lethargic or confused, or they might become completely obtunded. So associate that lucid interval with an epidural hematoma. Now, other signs and symptoms could include headache, vomiting, pupil abnormalities like a blown pupil, focal neurological deficits like hemiparesis or hemiplegia, and sometimes seizures. Now, on CT, an epidural hematoma is lens-shaped or football-shaped, and it's a collection of blood that's sort of shaped like a football. Remember, blood shows up bright white on a head CT. So a CT is a great test to look for intracranial hemorrhage. And in an epidural bleed, the blood is accumulating outside the dura, between the dura and the inner table of the skull. And I like to think about it just sort of peeling the dura away from the skull. And because the dura offers some resistance, it kind of extends inward and creates this biconvex hematoma that compresses the brain as it expands. This looks quite different from a subdural hematoma, which we're going to see in just a moment. Now, sometimes you'll hear that epidural hematoma will cross the brain midline on CT, and subdural hematomas don't cross the midline. And that's completely true, but I personally don't find it as helpful as the shape of the hematoma. Now, an epidural hematoma is a neurological emergency. It can lead to complications of irreversible neurological injury and even death. So the treatment is craniectomy to drain the hematoma and prevent mass effect. But while you're waiting for the neurosurgeon, you need to lower the intracranial pressure, which can be done by elevating the head of the bed to 30 degrees or so, hyperventilating the patient, and sometimes by giving mannitol. If you have an intracranial hemorrhage where the blood collects deep to the dura, between the dura and the arachnoid, this is called a subdural hematoma. Now, this is usually caused by rupture of the bridging veins following trauma. So an epidural is an arterial bleed, and a subdural is generally a low-pressure venous bleed. Now, there could be obvious head trauma like a motor vehicle accident, but also think about elderly patients who are on warfarin who fall and bump their head, and that warfarin makes them prone to bleeding. So anytime you have an elderly patient who falls, that's a contraindication for anticoagulation. And anytime you have an elderly patient with a history of falls who develops mental status changes, you probably need to think about working them up for a subdural hematoma. Subdural hematomas typically cause a headache that gradually worsens over days to weeks. They have this slow, low-pressure venous bleed, and the hematoma is accumulating much more slowly than that epidural hematoma does. You can also see mental status changes and somnolence, hemiparesis, and hyperactive deep tendon reflexes. Now, CT is going to show a crescent-shaped collection of blood. between the dura and the arachnoid. It sort of spreads out and forms this crescent shape. There's really nothing that's preventing the blood from spreading laterally, and so that's why it forms this crescent shape. Now, the only thing that limits the spread of blood is the falx cerebri, which is why subdural hematomas do not cross the midline. And if you still have trouble remembering which shape goes with which type of hematoma, a student suggested that the crescent shape is the one that's you see with a subdural hematoma. And then that biconvex eye-shaped hematoma is an epidural hematoma. But be sure you can identify each of these correctly on a CT or by just a verbal description of the hematoma. Now, the treatment for a subdural hematoma is very similar to the treatment for an epidural hematoma, either surgical drainage or supportive therapy, depending on the size of the bleed and the extent of the neurologic deficit. If you have a subdural hematoma, the patient's stable and has no neurological defects, it may just be something you can monitor closely and make sure it's not getting worse. It could resolve without much treatment. But if it is getting worse and you do have neurological defects, then you're going to need surgical drainage. In any patient that shows signs of mass effects, you're going to have to worry about the possibility of herniation. So in those patients, you do not want to do a lumbar puncture. So the test for a suspected subdural hematoma or a suspected epidural hematoma is going to be a CT scan, not a lumbar puncture. Now, if you have bleeding deep to the arachnoid, between the arachnoid and the pia, in the subarachnoid space, that's called a subarachnoid hemorrhage. And this is also a 4-star topic. The classic cause of a subarachnoid hemorrhage is a rupture of an arterial aneurysm or a Berry aneurysm. AVMs or arteriovenous malformations can also cause it, and so can trauma. But mainly I want you to think about Berry aneurysms. Berry aneurysms are associated with autosomal dominant polycystic kidney disease and also Ehlers-Danlos syndrome, which can lead to weak spots in the cerebral arteries that allows those aneurysms to form. Now, you may have also read that Marfan syndrome is associated with Berry aneurysms, but that's one of those classic associations that's turning out not to be true. So do not remember Marfan syndrome with Berry aneurysms. Remember polycystic kidney disease and Ehlers-Danlos syndrome. We've seen this image before with the circle of Willis. This is an angiogram of the brain that shows a Berry aneurysm right in the center of the image. Now, these can develop anywhere in the brain, but you're usually going to find them at a point where two vessels branch or bifurcate. The most common location of these intracranial aneurysms is the anterior communicating artery. The most classic presentation of a subarachnoid hemorrhage is a patient who comes in complaining of the worst headache of my life. So make sure you can recognize that. Anytime you hear worst headache of my life, you should think about subarachnoid hemorrhage. Now, retrospectively, there may be a history of recurrent headaches that are less severe in the weeks leading up to a big bleed. These smaller headaches are called sentinel headaches. So a sentinel is a guard or a sentry. So these are like the early warning signs of an impending big bleed. Unfortunately, they're usually not recognized as such at the time, but it might be an interesting piece of history. Now, subarachnoid hemorrhage can also sometimes present with neck pain, nausea and vomiting, maybe even some fever. And this sounds a lot like meningitis because all that blood is irritating to the meninges. So if a patient comes in complaining of the worst headache of his life, what test are you going to order to evaluate for a subarachnoid hemorrhage? Again, you're going to start with a CT scan. So CT is going to show blood in the CSF in the subarachnoid space. But if the CT comes back negative, you haven't completely ruled out a subarachnoid hemorrhage. In that case, the next step would be a lumbar puncture to look for blood in the CSF. So you could either see lots of red cells in an acute subarachnoid hemorrhage, or if the subarachnoid hemorrhage happened a few days ago, the red cells will have lysed and the hemoglobin will break down into bilirubin, and that's going to give the CSF a yellow appearance, which we call xanthochromia. So xantho means yellow. Now, ideally, when you do a lumbar puncture, the CSF is going to come out perfectly clear like water. But if it comes out bloody, you might think, well, I'm sticking a needle through the skin and through the ligaments, and maybe I just caused a little bleeding. We call that a traumatic tap. So how do you differentiate a traumatic tap from a subarachnoid hemorrhage? We're going to compare the number of red cells in the first tube of CSF that you collect to the number of red cells in the last tube you collect. We usually collect 3 or 4 tubes of CSF, and you're going to send one for protein and glucose, and you're going to send one for gram stain and culture if you're looking for meningitis. You're going to get a cell count on the first one and a cell count on the last one. So if there are 50 red cells in the first tube, but only 3 red cells in the last tube, that's probably just a traumatic lumbar puncture. So you have a traumatic lumbar puncture, your first collection tube is going to be very bloody. Doesn't necessarily mean you have a subarachnoid hemorrhage. But if your third or fourth collection tube is still grossly bloody, that probably means you do have a subarachnoid hemorrhage instead of just a traumatic tap. Then, once you've diagnosed a subarachnoid hemorrhage with your CT or with your lumbar puncture, the next step is to do an MRA or an angiography to localize the site of the bleeding. You need to figure out where the blood's coming from. If it's from an aneurysm, You need a neurosurgeon to go in there and clip it to stop the bleeding because that's life-threatening. So for the treatment, let's look at your study guide. First of all, you need to discontinue all anticoagulants and reverse any anticoagulation the patient might be on. You need to control the blood pressure. You want to keep the systolic blood pressure less than 150, but only if cognitive function is intact, because you have to make sure that you're maintaining adequate cerebral perfusion pressure. So if there's a neurological deficit and you lower the blood pressure too much, you run the risk of worsening the ischemia and making that deficit worse. The next blank is labetalol, which is the preferred drug for controlling the blood pressure. And the next bullet says to avoid nitroprusside and nitroglycerin because these drugs can increase intracranial pressure. Another drug we sometimes give is nimodipine, which is a calcium channel blocker that's going to prevent some vasospasm. You need to prevent physiologic derangements that may worsen brain injury. So you're going to avoid hypoxia and hyperglycemia. You're going to maintain a normal pH, maintain euvolemia, keep the temperature normal. And then the definitive treatment is surgical clipping or insertion of a metal coil into the aneurysm. Then the next bullet says that phenytoin for seizure prophylaxis is controversial and is generally avoided due to poorer outcomes. And you might do a ventriculostomy to monitor intracranial pressure in select patients. Then finally, we have parenchymal brain hemorrhage, which is bleeding within the brain parenchyma, sometimes also called intracerebral hemorrhages or just hemorrhagic stroke. Now, this is most commonly caused by hypertension, but other possible causes include AVMs, brain tumors, anticoagulation, and also drugs like cocaine or amphetamines that raise the blood pressure significantly could cause an intracerebral hemorrhage. Now, the presentation can include focal, motor, and sensory deficits like any stroke, but you might also see headaches, nausea and vomiting, seizures, or mental status changes. So this can look a lot like a CNS infection, like encephalitis. Now, on CT, you're going to look for a bright white hyperdense area within the brain parenchyma. Now, what are these other arrows pointing at? Well, that's blood that's leaked into the ventricles. But again, if a patient comes in with an apparent stroke and the CT comes back looking like this, you're definitely not going to think about giving this patient TPA. This is a hemorrhagic stroke. And then an MR angiogram or a CT angiogram could help you locate the site of the bleed. Now, you've already reviewed the treatment of the video on strokes. Supportive care, control the intracranial pressure, keep the systolic blood pressure below 200, and then rarely surgical decompression if they have a really large hemorrhage and the intracranial pressure is really high, because that's going to reduce the risk of uncal herniation and compression of the brainstem. All right, now we're ready for the end of session quiz. So pause the video, work through those questions, then we'll go over the answers. All right, first question. What type of brain hemorrhage is most likely in each of the following situations? So sudden onset of severe headache, vomiting, and meningismus. This is most likely a subarachnoid hemorrhage. That severe headache, that worst headache ever, comes on very suddenly and so severely it's sometimes called a thunderclap headache. Next one says, patient taking warfarin who falls and bumps his head. You're going to think about subdural hematoma. Brief loss of consciousness following head trauma, then rapid clinical deterioration hours later. That's an epidural hematoma with that lucid interval before they deteriorate. Then elderly patient with mild headache for 2 weeks, now becoming lethargic. That's a subdural hematoma. Patient with unilateral hemiparesis and blood pressure of 220 over 130. That should make you think of a parenchymal hemorrhage, a hemorrhagic stroke. Ruptured intracranial aneurysm will usually cause subarachnoid hemorrhage. Ruptured AVM is usually going to cause a parenchymal brain hemorrhage, but subarachnoid hemorrhages are also possible. Biconvex-shaped hematoma, or a lens-shaped or football-shaped hematoma, is an epidural hematoma. And then a crescent-shaped hematoma is a subdural hematoma. Next, what are the most common causes of an epidural hematoma and a subdural hematoma? So an epidural hematoma is most commonly caused by rupture of the middle meningeal artery, and a subdural hematoma is most commonly caused by rupture of the bridging veins following some type of head trauma. Next, what's the best test to order in a patient with a suspected intracranial hemorrhage? Remember we said CT of the head without contrast is going to be the study of choice. Now, MRI will also show bleeding very well, but CT is faster and less expensive. Next, what's the treatment for subarachnoid hemorrhage? So you're going to stop the anticoagulants, you're going to keep the blood pressure below 150 systolic, usually by using labetalol. You're going to avoid nitroprusside and nitroglycerin because those can increase intracranial pressure. You're going to give nimodipine to prevent arterial vasospasm. You're going to optimize the brain environment by preventing hypoxia, normalize the blood glucose, normalize the serum pH and osmolarity. You're going to optimize volume status, and you're going to prevent fever. And then ultimately, you're going to address the baryaneurysm or whatever caused the hemorrhage usually by surgical clipping or metal coil in that aneurysm. All right, that's it for our intracranial hemorrhages. I'll see you next time.
Oh, it feels so good to just sit down and relax and get a manicure after a long day on the wards, you know? Dr. Wilkerson was in rare form today. We admitted this old guy on warfarin who had bumped his head and now he has this little bleed. Totally not a big deal. But Wilkerson put up the CT and was all, "How can you tell if this patient has a subdural hematoma or an epidural hematoma?" And I totally knew, but I didn't want to say anything because Hagelmeyer and David are always giving me a hard time, calling me a gunner and stuff. I can't help it if I'm a total genius. Whatever. So, anyway, nobody else had any clue, and they were all looking at their charts and staring at the floor, and so Wilkerson looked right at me, and I said, "An epidural hematoma is lens-shaped or football-shaped, like a biconvex disc, and a subdural hematoma is crescent-shaped." And Wilkerson just said, "Strong work, Miss Henry." But then for the rest of rounds, Hagelmeyer was all, "Strong work, Miss Henry," every time I said anything. What a jerk! I love that color on you. What is it? Manic magenta? I'm so getting that when I do my psych rotation next month.